Hello everyone and welcome to this online virtual med administration class. A little bit about today, we are going to be talking about bloodborne pathogen safety, medication administration, as well as the types of medical documents that you're going to encounter on a daily basis within our programs. When this class is done, I will be directing you to do some self-guided work through the Staff Resources website. There are 3 videos that need to be watched along with 2 electronic quizzes that get sent to me automatically. There is a total of 4 training hours that you can log into your time card entry system for completing this course. If you have any questions about accessing the website or changing things on your time card, please ask your program director and they will gladly assist you. Hello, my name is Alice Schrader. I am DRCC's RN consultant. So I'm the person that your program directors, senior directors all go to regarding all types of medical situations with our clients. I also was a staff nurse for 5 years at Crystal Program. I've been a nurse for over a decade working with different types of vulnerable populations here in the Twin Ports, ranging from the homeless population all the way to the types of clients that we serve with DRCC. This is an amazing, positive, inclusive company to work for, and I wish you many, many happy years with us. I am sure you'll be seeing my face popping in and out of your programs through your time with us as well. If this were an in-person class, I would be having you all watch a video on bloodborne pathogen safety. However, this is one of the 3 videos that you will be watching at a later date, so I'm going to go ahead and skip ahead. I'm going to go ahead and talk briefly about bloodborne pathogen safety. Bloodborne pathogens are small infectious microorganisms that live in the human blood, and they can cause certain diseases in humans that we call bloodborne diseases. Bloodborne pathogens reside in materials that we call potentially infectious materials. We say potentially infectious because even if you were directly exposed to this type of material, it doesn't mean that you're automatically going to contract a bloodborne disease. For example, if you were to have a needle stick from someone who is HIV positive, your chances of contracting HIV are 1 in 200. So it simply means that the potential is there. When we think about potentially infectious materials, we're mostly concerned about blood, any type of fluid that's containing visible blood. There are multiple routes that you can become exposed to a bloodborne pathogens, including sexual routes, more surgical and medical routes as well. So it's just important to treat all body fluids in situations where it's difficult or impossible to differentiate where those body fluids came from as a potentially infectious material. There are also things called non-potentially infectious materials. And we say non-potentially infectious because if you were exposed to these materials, you are not at an immediate risk of contracting a bloodborne disease. However, they can still transmit and carry bacteria, so we need to take proper care using PPE when handling these types of materials. We do treat an exposure to both potentially infectious and non-potentially infectious materials, everything besides sweat and tears, as an exposure incident. And the reason that we do so is because in non-potentially infectious materials, there could be blood that is present that is invisible to the naked eye. So we just want to make sure that we cover all our bases and keep everyone safe. The 2 types of bloodborne pathogens that I'm going to talk about today are HIV, which stands for the human immunodeficiency virus. This works by attacking the body's T cells, which fight off infections. So someone who is HIV positive is left susceptible to all different types of infections, especially rare infections that someone with a normal strength immune system would be able to fight off. And there's hepatitis B, which is a virus that attacks the liver. It can cause fast acting as well as long-term, lifelong liver damage. And right now there are no known cures for both of these viruses. When I talk about types of exposure in the workplace, I like to relate it to zombie movies because just like everybody in the zombie movie, they want to avoid being infected by that particular virus. And how that's done is because it gets directly introduced into that person's bloodstream. So if we think about ways at work that could happen to us, through needle sticks, cuts in our skin, those infectious materials could come in contact with the mucous membranes of our eyes, our nose, our mouth, broken skin. Someone could bite us and break the skin. There could be blood and saliva that's in their mouth that now entered our bloodstream that way, as well as splashes and punctures. So if you are emptying out a urine bag into a canister, those droplets of urine can drop off and get in your eye, get in your nose, get in your mouth. So it's just important to think about the types of activities that we're performing and how to best protect ourselves. So when we are trying to avoid an exposure incident from happening, it's important to just think ahead. Treat all blood and body fluid spills as if they were potentially infectious. Wear appropriate PPE equipment, gloves, goggles, gowns, depending on what parts of your body are exposed and at an immediate risk of becoming exposed or coming in contact with a potentially harmful material. Clean up contaminated broken glass with tongs, forceps, brush, a dustpan. Never ever pick up anything sharp that could potentially cut you with your bare hands, even if you're wearing gloves, because those little rubber gloves are not going to protect you at all from anything sharp. So you always want to use a secondary barrier when cleaning up those types of things. Handle all trash as if it contains sharps or infectious items. It's a really bad habit that we all get into. When we see a full trash can, we want to stick our hands in there and just push it down and make more room. It's a dangerous habit to get into because we are not sure what exactly is all in that garbage can. So you could put your hand in blindly and get punctured with something sharp, and then you would become exposed. So it's just a great habit to get into. If you see a full trash can at work, just take the bag out, throw it away, and put a new bag in. I bolded this next one because washing our hands is the easiest and most efficient way to decrease our chances of transmitting germs to ourselves. Bacteria is so tiny that it can get underneath your fingernails. It could get into the cracks of your skin. So if we are putting on makeup, if we're eating food or smoking a cigarette, we're introducing those bacteria to ourselves that way. So after we've completed a task and removed PPE, you're going to wash your hands or affected body parts with soap and warm water. Vigorously scrub all areas for at least 25 seconds, or the ABC song, sung twice through. And when we're rinsing our hands, make sure that your hands are pointed downwards so the water runs into the basin instead of up, so then we have dirty water running down our arms and into our clothes. In COVID world, we are all experts at hand hygiene, so just continue to do so. And lastly, we're going to place potentially infectious materials and contaminated items in closable containers or bags. They're usually color-coded red or red-orange, and they're marked with a biohazard label. If you have clients that receive maybe diabetic care and they have sharps, something like that, we'll never, ever, ever put anything that was directly exposed to somebody in the trash can. You need to put a sharps in a sharps container. If there's a lot of blood, you need to put blood in a biohazard bag. You can't just put that in the trash with everything else. So if you are not sure where these things are located in your programs, make sure that you ask your program directors and they will gladly show you where they are. What to do if you are exposed? The first thing to do is just don't panic. We have a set list of steps for you to follow. The first step is you want to take care of yourself first. So get that potentially infectious materials off of you, off of your body as quickly as possible. So wash or rinse the area. If you have to flush out your eye, you have to flush out your mouth, your nose. Make sure that it's off of you. And if that exposure happened because of an injury, make sure you follow first aid. Make sure that you're stable and safe first. Next, you're going to contact your program director right away. If your program director isn't available that day, all you need to do is call the main office and ask for any of the senior directors, and they will gladly assist you with the next steps. The next step is within 24 hours, you need to fill out an exposure incident report. All of the medical documents are located on the staff resources website. An exposure incident report has a little information about you, the client that you were exposed to. It's a description of the incident, what happened, what material you were exposed to, what part of your body was exposed, and the action, meaning how were you exposed? Was it a needle stick, a bite, a skin tear, etc. On the back of that form, you have a couple options. If you haven't been vaccinated against hepatitis B, you have the opportunity to become vaccinated. The hepatitis B vaccination is a series of 3 shots. One is given right away, the next is given 3 months later, and the next is given 6 months later. You can also choose to have your blood tested or have the client's blood tested. If you choose to have your blood tested, it will be tested 2 times over a period of time for HIV and hepatitis B. If you choose to have the client's blood tested, it will be tested 1 time for HIV and hepatitis B. And if those results come back negative, then it's only assumed that you are negative as well. That being said, if you have any questions at all about our client's medical history, all of that information is freely accessible to you. If you've started training in your programs, you've already started looking through our clients' medical books. So if you have concerns about bloodborne diseases, things like that, all of that information is not hidden. So feel free to get comfortable with your client's medical history. On the very bottom of that form, you do have the option to refuse any vaccinations or blood tests. This is an option that only you can make. Your program director can't help make that choice for you. Coworkers can't make that choice for you. You just have to do what you're comfortable with and what is best for you. And again, DRCC pays for all vaccinations and all testing that come from an exposure incident at work. More information about bloodborne pathogen safety in the workplace will be available in that video that you're going to be watching a little later. If you do have any immediate questions about bloodborne pathogen safety or an exposure incident, you can always feel free to reach out to me at any time via email or text message. Now we are beginning the medication administration content. So if you have that outline that I had sent to you, now you can begin to just fill in the blanks. I really like to use this picture because it is not an accurate way at all of storing or dispensing medications, and I think it's kind of funny. The purpose of this class is to prepare you for the 4 most common types of medications that you're going to encounter on a daily basis within our programs. If your clients receive medications in other ways, so maybe injections, diabetic care, maybe they have some feeding tubes, that requires additional training that your program director will set up with me at a different time. So the purpose of today's class, we're just going to talk about 4 main types of meds. Oral meds. So these are everything that you would enter into someone's mouth. So it could be pills, capsules, which are those little plastic things you pull apart and there's powder or little pellets inside. Liquids, dissolvables, sprays, anything that would go in a mouth is an oral med. Topicals, these are medications that absorb into a person's bloodstream via the skin, and this is what we call transdermal application. So topicals can be anything like lotions, creams, ointments, powders, even patches, anything that goes directly on top of the skin. And eye drops, ear drops, those are pretty self-explanatory. So first off, whenever you are preparing medications, that needs to be your first and foremost important task. You don't want to get pulled away. You don't want to get distracted. So it is perfectly fine to tell clients that they need to wait a while. Ask coworkers to help assist you with some things, go help a client, make meals, answer the phone, things like that. You're never going to get in trouble for asking for help in that way. Once you've started setting up meds, ideally you want to start from the beginning all the way to giving the client their meds and signing off on the MMAR, and then moving on to the next task. You don't want to get interrupted in between those steps. That's when med errors occur. If you do end up having to be pulled away, you need to make sure that all the medications, everything is locked away in the med cupboard. You aren't leaving any keys, any medications out in the open. because that could pose a danger to our clients. So oral meds, we're going to wash our hands. We do not need to wear gloves at all when we're administering oral meds. The client is going to come to the med area, or we're going to bring the meds to them while they're sitting up. Ideally, we want to avoid giving medications if someone is in bed, if at all possible. Inevitably, something is going to spill, and you're going to try searching for a little tiny white pill in the bed sheets, and that's going to be nearly impossible. So it's best to always give someone any type of an oral medication with them sitting up. They're alert, they're ready to swallow their pills. It also poses an aspiration risk as well if someone is laying in bed when we're giving them meds. And you're always going to offer them something to drink. I've seen some clients able to swallow pills without water or something like that, but that is a rare talent that very few possess. Special considerations for oral medications. Crushing. Staff are able to crush medications. However, there needs to be a specific doctor's order that those medications can be crushed or not. So we can't come to work one day and decide that we're going to start crushing medications to see if it would be easier for Susie to swallow. We need to have a specific doctor's order for those meds to be crushed. And we also need to make sure that those meds can be crushed. So always look for stickers on med bottles, on the pill cards that says do not crush. There's little stickers. Also, we're never going to crush something that says it's an extended release tablet or like a 24-hour release tablet. So always be aware of the medications that you are crushing. When we are crushing medications, you're going to put all the meds that can be crushed together in the little pill crushing pouch. You have to use an approved pill crusher. You can't use a spoon or something like that to crush meds. You have to use a pill crusher, which your programs will have. So you'll put all the meds together that you're going to crush. Put the granules in a med cup, a small med cup. Maybe there's capsules or things like that. That's when you would tear them apart or pull them apart and put the contents in with the granules in the med cup. And next, with crushed meds, you need to mix it with something. So you're never going to dump dry granules down someone's throat and hope that they swallow. You always need to mix it with yogurt, pudding, applesauce, whatever the client prefers, but it just needs to be mixed and enough for just 1 or 2 bites. You're never going to just take granules and put them in a big bowl of pudding or applesauce or things like that because they might decide that they're not hungry anymore and they don't want to eat it all, and then they didn't get the right dose of their meds. So just enough for 1 or 2 bites, that's all you need. And lastly, splitting medications. Staff are able to split medications. However, that medication needs to be scored. And what that means is there is a thin line right in the middle of that pill. And when it's split at that line, it's 2 equal half doses of that medication. If you're looking at a pill and there is no line, there is no score, that means that it cannot evenly distribute that half dose of that med. It's unable to be split. So you need to use an approved pill splitter. You can't break it with your fingers, you can't use a knife or anything like that. You need to use an approved pill splitter, which programs should have readily available as well. So topical medications, we are going to wash our hands. We need to wear gloves whenever we are administering a topical. We don't want that medication to absorb into our own bloodstream, so we need to protect ourselves. You're going to follow a prescribed amount if it's applicable. Sometimes topicals will come with a clear plastic card with a black line on it. This is what we call the dosing card. And when you apply that topical along that line, that's the correct measured amount to apply on the body. If there is a prescribed amount, and also the area that you're going to apply the topical, that needs to be specifically stated on the MAR. If there is no area specifically put there, never ever try to guess and put a topical somewhere. It needs to be clearly stated. Make sure that you get some clarification before administering that medication. And all topicals and personal treatments that expose anyone's skin, we need to administer in the bedroom or in the bathroom. These things can't be administered in common areas of the house, and this is just for privacy and dignity reasons for our clients. When we're applying eye medications, you're going to wash your hands. We're going to wear gloves. You need to protect ourselves. You're going to be coming in close contact with that person's mucous membranes of their eyes. Have them sitting straight up. Make a pocket with the lower lid if they're able to. Otherwise, you can pull their lid down and make a pocket yourself. When you pull that lid down, have them look straight up at the ceiling, and then you're going to apply the prescribed amount of drops into that pocket. And again, which eye and how many drops needs to be clearly stated in the MAR. If it is not stated, do not apply those drops. You need to get clarification before you do. Also, whenever you're applying anything into the eye, make sure that the dropper, the dispenser, is not touching the actual eyeball itself. You need to have a little bit of space there. If you touch it to the actual eyeball, then you could potentially scratch a person's cornea, and you also contaminated that apparatus, and we need to disinfect it before we can use it again. Sometimes eye medications can come as an ointment instead of a drop. And in that case, it still follows the same concept where you'll make that pocket with the lower lid, put a thin ribbon of that ointment along the lid there, and it'll absorb into the eye that way. Eardrops. We're going to wash our hands. We're going to wear gloves. We want to protect ourselves. We're going to be coming in contact with their earwax. You're going to have the client sitting up with their head tilted to the side, or else they could lie down if they want. Just as long as the ear that you're going to apply the medication to is facing upwards. You're going to take the very top of the ear. It's what we call the pinna. So you'll take the pinna, you'll pull up to the ceiling, and then pull back towards their shoulder. And what this does is it straightens out the ear canal. In adults, naturally, our ear canals are curved. So what that does, you want to straighten it out so the medication can get in there the furthest and have the best effect. Pulling up and back is what we do for adults. If you're working with an infant or a toddler, instead of going up and back, you would pull down and back. Again, placing the prescribed amount of drops in the ear. Again, if there is no ear clearly stated, the amount of drops clearly stated, do not administer that medication and get clarification before you do. Have the client stay in that position for a couple of minutes if they're compliant. Otherwise, if they want to walk around, do whatever. You can put a cotton ball in their ear, or paper towel, toilet paper, whatever is around, and just take it out after a few minutes. So it's staff's responsibility to know all about the medications that we're giving to our clients. And a really great resource to utilize is called a nursing drug guide. And this is like a dictionary for all kinds of meds. And each program should have one either in your program director's office or in the med area. How it works is you'll look at the pages and you'll see in the very back of the book there's a section that's colored. It's usually blue or purple or pink. So you flip to the back of the book and every medication that you can think of is listed in alphabetical order by both brand name and generic name. So a brand name always starts with a capital letter, and this is the name that the company that manufactures and distributes that medication they come up with. So when you see commercials on TV for Cymbalta, Viagra, Celexa, things like that, those are called brand names. Generic names always start with a lowercase letter, and generic names exist so physicians, pharmacists know what medications a person is on, regardless of the brand that's manufacturing it and making money off of it. So a medication could have many, many, many brand names, but will only always have just one generic name. So if you know what medication you're looking for, you go into the back of the nursing drug guide, you'll locate the name, it's in alphabetical order. There's a corresponding page number. So you'll flip to that page in the book, and there is a section dedicated all about that medication. It'll tell you all the forms it comes in, the proper dosages for adults, geriatrics, pediatrics, nursing considerations, lab values, and there's a section that says adverse reactions. So adverse reactions and side effects, they mean the exact same thing. And the side effects in a nursing drug guide, the ones that are in bold print, those are the ones that are the most serious, most rare. So a nursing drug guide is a really good tool. You can also utilize the printouts from the pharmacy that get delivered with a new medication. We do keep those papers in the back of our clients' medical books, so you can look through there if you have questions about meds. And you can also just call the pharmacy itself. They are used to receiving phone calls about medication administration. So if something is concerning, You want answers right away, feel free to call the pharmacy and they will be happy to assist you. So psychotropic medications are medications that alter the chemistry within a person's brain. They can be called psychotropics, also called antipsychotic meds. And we only utilize them for two reasons, to control a behavior and to stabilize a client's mood. We never, ever introduce a psychotropic medication for staff convenience. So for an example, there was a client who liked to slap her face, and it's kind of a behavior. And she liked to take her fist and like to pound on surfaces that she was around. Eventually, she slapped her face to the point of developing cellulitis within her skin tissue, which is an infection of the skin tissue. It can cause someone to become septic, which is very serious. And eventually, she took her fist and she pounded through a window, and it shattered and it cut up her arm and her wrist really bad. So this would be an example of when we would consider to introduce a psychotropic med into her medication regimen. The reason that we are so hesitant to introduce a psychotropic medication are the side effects. These side effects can become permanent even if that antipsychotic medication is discontinued. So these are extremely, extremely potent medications that we are giving to our people. So it's important that we understand these medications and the implications that arise when we give these meds. Typically, a person needs to be on an antipsychotic for over a year before these side effects can occur. However, there are instances and certain side effects that can occur right away. One of these side effects is tardive dyskinesias, which are small muscle movements that the person doesn't even know that they're making. So it could just be a slight twitch of the eyebrow, twitch of the nose, maybe the tongue kind of quivers in their mouth, their toes kind of twitch, they kind of sway side by side, things like that, but they have no idea that they're even doing it. Those are tardive dyskinesias. Neuroleptic malignant syndrome. This is one side effect that can occur right away if someone first begins a psychotropic med. And it's manifested by mild flu-like symptoms. And then later on, it will escalate into an elevated blood pressure, elevated temperature. It doesn't occur very often, but when it does, there's a 25% chance of death. So it's a very serious side effect to be aware of. And then akathisia. This is probably the most common side effect that occurs from a psychotropic med. And what it looks like is someone is severely uncomfortable or they have bad anxiety. So they could be shifting their weight a lot in their chair. They have a hard time sitting still. Maybe they kind of fumble with their fingers, kind of bring their hands together, kind of look around. They just seem very agitated. That's what akathisia is. All of our clients who are prescribed a psychotropic med are assessed by the program director a few times a year. However, you are the people that have the most eye contact with our clients. So if you notice something that seems a little bit off, bring it up to your program director's attention as soon as possible so we can treat any potential side effect that could arise from their meds. So moving on to medication storage. All of our clients need to have their own designated space specifically for their medications and treatments. It could be either their own cabinet, their own drawer, their own shelf, things like that, but it needs to be clearly labeled with their name, and it needs to be locked at all times. And also the keys that get into a medication area need to be either on our person at all times or locked in an office somewhere safe. We're never going to leave keys to areas in the house just out on counters or things like that because that's easily grabbed by our clients. Within that med area, there needs to be a division between the medications that are taken by mouth and then medications that are taken by other ways. So sometimes you can use a divider like this. Otherwise, I've seen programs use plastic baggies or plastic cups. It doesn't matter what it is, just as long as those two types of meds aren't touching. Medications that require refrigeration, they need to be locked in a specific medication fridge. There needs to be a specific location for medical things that are refrigerated. I made this mistake as a new nurse once, and I put a stool sample in our refrigerator with everybody's break food. So there just needs to be a specific location for those medications. If medications are locked in the medication fridge with a padlock, that's fine. Otherwise, if there is no lock on that fridge, there needs to be a lockbox within that fridge. The keys also must be locked and carried on your person at all times. There's also a flow sheet that is attached to the medication fridge. This is just a daily check-off where you check the temperature, just making sure that the fridge didn't die overnight or somebody didn't accidentally bump the thermostat. If the temperature gets too hot or too cold, it could damage the integrity of the medications that are within that fridge. Clients who are prescribed narcotics, we sign off on the MAR like a normal medication. However, we do two additional things. We need to do a med count before and after that medication is administered, and we need to have a witness signature. All of these things are located on a thing called a narcotics record, which will be attached to the MAR. A lot of the time, narcotics are analgesics for pain. So that being said, you need a witness sign-off. A witness doesn't necessarily need to be present in order for you to administer that medication. It is not acceptable to deny a client a pain medication simply because there is nobody else there to sign off on the narcotics record. In those situations, so say you're working on an overnight or on an outing or the only staff in the house, you would administer that medication like normal. And then when staff is available, then you would just sign off and do the med count then. Narcotics also have a double locked system, so they need to be locked away in a client's medical area, and they need to live within a lock box. So it's a two-lock system. I'm not going to go too in-depth about the MAR because that is included in the videos that you're going to be watching a little bit later. But I will say, whenever we're signing off on the MAR, you want to get into the habit of signing off immediately after you've completed the task and there were no problems. If there is a spot that's left blank in the MAR, what that looks like is that treatment or that medication wasn't completed. So that puts our clients at risk of missing out on a med or maybe getting double dosed by a med. So always get in the habit of signing off immediately after you've completed that task. Your program directors have every right to call you back into the program to sign off on a MAR if you've forgotten. So don't wait until the end of the shift to sign off on the MAR because inevitably you will forget. Whenever you are preparing a medication, with every medication that you need to pass and set up, you're going to compare the 5 rights of medication administration 3 times. And what that means is you're going to compare the information that's on the medication package to what's on the MAR itself. You're going to be comparing the right dosage, the right route, meaning how that medication is taken. So you're not going to give an oral med through the nose or something like that. So make sure you're giving it the right way, the right time. With DRCC, there is a 2-hour window that a medication can be given. So if that medication is due at 7 a.m., you have from 6 a.m. to 8 a.m. to administer that medication. If it is given outside of that time window without approval from a nurse or a doctor, then it is considered a medication error. You're going to check the right person, making sure that the names match, and then also making sure that the medication name matches as well. So once you have compared the 5 rights of medication 3 times for that medication that you prepared, the risk for med errors decreases immensely. I get so many medication reports or error reports that could be completely alleviated if someone was doing their safety checks. It seems like it's something that is a bit excessive, but over time it's something that you're going to become very fast and efficient with. When you're doing your 6 shadowed med passes in your programs, your program directors and assistant program directors are going to specifically be looking for making sure that you are checking the 5 rights of medication with each pill that you're setting up. In the video demonstration that you're going to watch a little bit later, I demonstrate when to compare the 5 rights when during your med prep. If this were an in-person class, I would be demonstrating how to do a med pass correctly, and then I'd be asking you to come into my office to demonstrate the skill so I could check you off. Since this is a virtual class, the med pass demonstration will be one of the videos that you're going to be watching at the end of this class on your own. So DRCC is never punitive at all when it comes to medication errors. However, if you attempt to cover up a medication error, if you lie about it, try to hide it, then that's grounds for immediate dismissal. We use med errors as an opportunity to provide more training if needed. Some common med errors that can occur: a missed dose or a double dose. I've seen these things happen when coworkers aren't communicating with each other and they think that one or the other is supposed to be giving meds, or they already gave meds, so then clients didn't get any, or they got too many meds. So always make sure that you're communicating well with your coworkers about medication-related things. And also medications given to the wrong person. This can be done completely by accident, which is another reason we don't ever leave medications sitting out in the open for someone to grab and swallow. And another reason why we don't ever pre-set up medications ahead of time. I know it seems like a time saver to pop out medications and lock them away and have your big morning med pass easily accessible, but what this does, it provides an attitude of complacency. So that makes it easy for a med error to occur. So for example, we had a staff that worked here for 20 years. She got in the habit of setting up her meds ahead of time. Morning, she got real busy, grabbed the wrong pill cup, gave the wrong client the wrong medications, and sent that client to the hospital unresponsive for a few days. So don't ever preset up medications. You always want to start a med pass from the beginning all the way to giving those meds and then signing off on the MAR before moving on to the next person. Whenever a medication error occurs, we need to fill out an incident report, which I'm going to talk about next. Incident reports are filled out for all different kinds of reasons. If you're not quite sure if that particular incident type requires one or not, right in the beginning of the incident report are all the different types of situations where one would need an incident report, so you can read through and see if any of those match. Incident reports are all online. They're easy to fill out through staff resources in the medical documents tab. You just fill them out on the computer and print them out. You don't need to handwrite anything on them. An incident report consists of what happened, the staff response, any doctor recommendations, and who all you notified. So doctor recommendations are required if there was a certain injury, if it was a medication-related incident, something that you would need a licensed professional to give you some feedback on. If that particular medication error was a missed dose or a double dose, you can look through a client's med visit forms, and on the back of those forms, you can see the physician will write some feedback about what to do if there was a double dose or a missed dose. So if that feedback is there, then you do not need to contact a doctor. You fill out as much as you can and you turn it into your program director, who will then get it to where it needs to go. While you're all administering medications, you are doing so under my own license, so I do get a copy of all incident reports, especially ones that are medication related. I use this to keep track, keep tabs if there are certain programs, certain people, if there are medication errors that may require additional training. So please, if you have any issues, any concerns about medication administration, to again, contact me at any time and I'll be happy to answer any questions for you. Things that could go wrong during a med pass. Someone could refuse their meds. Everyone has the right to refuse their medication. A typical practice that we use for DRCC is we explain to our clients what that medication is used for, give them 15 minutes to kind of cool off, and then approach the subject again. If they're still refusing their medications, if you have them already popped out, the pills in a cup, make sure you put the pills in a pill envelope, you put the date and time and lock it away in their med cupboard to be disposed of. You need to write a medical note that they refuse their medications, and on the MAR, instead of writing your initials, you're going to put an R, which is another reason why we don't ever want to pre-sign anything on the MAR out before we've done a task. If that medication was a liquid med is not considered contaminated if it's within the med cup. So you can go ahead and pour it back in into the big bottle. There will be no problems there. You also need to write an incident report that they refused their medications. You are never ever going to be held responsible for a client refusing their medications. So don't ever try to bargain with them. Don't ever try to coerce them. Don't try to hide the medications. These are all forms of human battery. So we need to respect our client's human right, and if they do not want to take their meds, we don't push the subject. If a client throws up after taking their medications, all you need to do is simply clean up the mess and write a medical note about what happened. We don't need to change anything on the MAR. You don't need to write an incident report. The most important thing to remember, though, is we're not going to re-administer those medications. Even if we can clearly see full pills in their pile of vomit, we're not going to re-administer those medications, because as soon as something enters a person's mouth, the digestive process has already started to begin. So we aren't sure how much of that medication was already absorbed into their bloodstream. To play it safe, you don't re-administer those meds. Something could drop on the floor. Accidents always happen, but there's just no 10-second rule when it comes to medications, and we can't use those meds anymore. But we still need to be held accountable for those meds. So if you spilled some pills on the floor, you can go ahead, pick those pills up, put them in a pill envelope, put the date and time to be destroyed, and lock them away in the client's med area. We never want to destroy medications on our own. This is a duty of your program director. There is paperwork that needs to be filled out, so always just store them away to be disposed of at a later date. If that medication was a liquid med, obviously we cannot save that med, so you're just going to clean up the mess, and that'll be good enough. You need to write a medical note whenever we have wasted a medication, because there could be a potential where medications are short for the month. Their supply will be short now that we wasted meds. So we need to have documentation that there was an incident, just so pharmacies are more comfortable giving medications ahead of time. PRN medications are taken as needed, and they're oftentimes used for comfort. On the back of a client's annual physical form, they get approved every year by their primary physician for a list of commonly needed PRN medications. So Tylenol, cough syrup, things for diarrhea, indigestion, athlete's foot, things like that. But of course, doctors can prescribe other PRNs as well. When we are administering a PRN, we document them a little bit differently. So we still sign the same on the MAR. However, we're going to utilize two boxes. So first you'll put your initials, and then directly underneath those initials you need to have the time that you gave that medication. PRN prescriptions are written in a way where there's a specific time window that medication can be given. So for example, give 4 pills every 8 hours, or give 1 pill every 12 hours, things like that. So you just need to make sure that the timestamp is there so the oncoming staff know that they're within the right time window that PRN can be given. Every time you give a PRN, you need to also write a medical note, and this slide here, this is what you need to include in that medical note. An hour after, at least an hour after you've given a PRN, you need to write a second note right directly following this note, and we call it a follow-up note. And what that means is we're just documenting if that PRN was successful or not. So it seems like a little bit excessive, but we need to have a follow-up note so physicians can have documentation if a certain PRN isn't successful or not, if we want to consider changing someone's PRN prescriptions. Ways that you could follow up with the client, just simply asking them if they feel okay, if it seemed to help. Nonverbal clients, you can see if maybe their body language is a little more relaxed. They don't seem as tense. Even if someone is sleeping, this could be determined as successful or not. We're never going to ever wake someone up from a nap and ask if their PRN worked. If someone's comfortable enough to sleep, it's assumed that PRN was successful.
Whenever we're taking a client to a medical appointment, we need to have a medical visit form with us. It's all online. You fill it out on the computer and print it out. On this form, you have the client's name, the date, who they're going to see, why they're going to the doctor, what facility they're going to, and then all the medications that person is on. And this needs to be the most up-to-date and accurate list. So you want to make sure that all the medications that you listed match exactly how it does on the client's MAR. These forms are how physicians know what's going on with our clients, so it's important that we uphold a strong reputation for DRCC when we're handling the community here, the medical community here. So always, always, always be prepared. In the middle of the med visit form, there is a spot for allergies. It often gets overlooked. Even if our clients don't have any allergies that we're aware of, we do need to put something there, like no known allergies or NKA, something just so we're not leaving it blank. Because if it's blank, then physicians aren't quite sure if there are any allergies or not. If you've already started training in your programs, you're quite familiar with individual and medical notes. Individual notes are just a recap of everything that occurred during your shift. So things that happen, behaviors, things like that. Medical notes pertains to all things medication related, health related, medical appointments related, things with our clients. Anyone can write in either notes. It doesn't need to be just a health professional that writes a medical note. So all the notes that I was talking about during this presentation, you would write in the medical notes section. Whenever we're handwriting on our notes, individual or medical notes, you're going to use only blue or black ink. If you make a mistake in medical notes, you're going to draw a thin line through that error and initial. These are legal documents, and they can be gone through by health services and used as an investigation evidence. So it's important that it doesn't look like we're trying to hide anything. So we can't use, or don't use marker to black something out. Don't ever use white out. Don't scribble anything out. Try to erase anything. It just looks a little fishy. So you're never going to get in trouble for documenting an error. You just need to know how to document that error correctly. Whenever we're writing in a medical note, we need to write objectively versus subjectively. So what that means is we're writing exactly what we see and not what we feel. So instead of writing Marianne is really anxious today, we would write Marianne is pacing around the house. She's talking to herself. She's wringing her hands together, very impatient. Things that we are observing that would make us believe that she's anxious. That's the types of things that we need to document in our notes. The more details that we have is more helpful to a physician in the long run. So always write objectively versus subjectively. Some programs utilize their notes on computers now. If still follows the same concept, they are legal documents. So if you do make an error, make sure that you're running spell check, make sure that you have proper punctuation and things like that before submitting. But if you do realize that you made an error after submitting, you can't go back. It's permanently in the database. So in those situations, you just have to write an immediate note right after explaining what that error was, and then you would submit it. Also on medical notes, it's important to always write a note pertaining to the medical visit if you took a client on an appointment. So basically, it's just a recap of everything that is on the med visit form, why they went to the doctor, the client's name, the date, concerns that the doctor discussed with you, concerns that you discussed with the doctor, any medical tests and the results of those medical tests, any medication changes, when they want to be seen again. Just a nice clean snapshot of everything that occurred during that medical appointment. We can't take all of our clients on appointments, so we rely on you to have thorough documentation so as to not create a delay in our clients' care. If this were an in-person class, I would have a handout that had a bunch of commonly used medical abbreviations. Medical abbreviations exist for health professionals to limit their handwriting time. They're not used as often anymore, but it's something that does still come up. Medical abbreviations are based off of Latin. So what they mean in English does not necessarily match the letters presented. So for example, PRN means to take as needed. QID means 4 times a day. PO means to take by mouth. So if you do see letters that are on a medical note or on a prescription of some sort, these letters do mean something. So you can utilize a nursing drug guide to clarify. Otherwise, you can use trusty Google. It's just important to understand that don't ignore any type of letters that don't make any sense, because it's most likely that they do mean something. If you have any questions at all or things that were unclear from this presentation, or throughout your time with DRCC, please feel free to ever call me with any questions about medication administration, bloodborne pathogen safety, documentation things. Best way to contact me is via email or text message. My phone number should be posted within your program, as well as my email. So again, I wish you much luck with DRCC, and I'm sure I'll be seeing your face in the future.